Good afternoon and welcome everyone to McFarland Clinic's webinar, Lung Cancer Screening, Early Detection Saves Lives. My name is Shelley Jakey. I'm the Marketing and Public Relations Director for McFarland Clinic, and I'm going to be serving as your host and your moderator for today's session. Our guest speakers and experts and physicians from McFarland Clinic on this topic of lung cancer and lung cancer screenings, Dr. Mahyni with critical care medicine and a pulmonologist at McFarland Clinic. He's based in Ames, and Dr. Tofilon, our medical oncologist who is based out of our Fort Dodge practice there. So those will be our two speakers for today. They will be covering understanding lung cancer screening and how to get screened, early detection, the patient journey and from screening to care, and then advances in lung cancer diagnosis and treatment. A couple of various areas that I know Dr. Toflin's going to speak to that a little bit later in the program. But important thing about all of this is with lung cancer screening, who is eligible to screen and how do you get screened? And so our experts are going to be going through that. I do have a couple of housekeeping items for you. The opportunity for you to ask questions along the way. There's a Q&A function in this Zoom format. Feel free at any point to type in a question or comment that you have. We're going to reserve those for at the end of the total presentation. I'm going to be watching it as they come in, and then I'll share those back with our physicians to be able to address some of the questions that you have. We are recording this webinar. Anyone who's registered for this webinar will receive an email with a link to a recording, possibly by the end of the week or early next week. And we do place that on our McFarland Clinic website as well and promote it through our social. So if you're watching and you want to share it with a friend or a family member, know that this is being recorded and can be shared back out. At the end of the Zoom presentation, we do offer a survey. We'd like to hear what were some of your takeaways or impressions about the webinar. And we always like to hear about other healthcare topics that are important to you and that you'd like to hear from our McFarland physicians and experts. So again, I'm going to welcome our first speaker, Dr. Mahyni with critical care medicine and pulmonologist here in Ames. He's going to take us through the first half of the presentation. Good afternoon, Doctor.
Thank you so much, Shelley, and thank you for having me today. And thank you for everybody who's listening now and going to be listening later. And welcome to Lung Cancer Awareness Month. I think there's probably a lot of people who don't know that November in itself is Lung Cancer Awareness Month, which is why this talk today is just so appropriate. My goal today really is to talk about lung cancer screening, the importance of lung cancer screening. So really, what is lung cancer screening? Why do we do it? And then what happens after you get it? And I very much look forward to Dr. Toflin's talk as well. I will say anecdotally in the realm of lung cancer screening and treatments and diagnostics, we've probably made more advances in the last 15 years on this field than in a long period of time. So let's just start with some basics in terms of what is lung cancer screening. And simply put, it really is a CT scan. And you can see this picture on the right is a picture of a CAT scan. Black is normal lung. The little white things you see there are blood vessels, and that's a normal cut of a CT scan. The purpose of lung cancer screening is to detect lung cancer before symptoms appear, and we do know statistically that it improves outcomes through earlier interventions. What technically a low-dose CT scan means is that you go to a radiology department at your local facility, and the CT scan itself is about 3 minutes of screen time, which is why we call it low dose. And in total, it's about a 10-minute appointment. So it really is a pretty quick thing. So the primary question then becomes, well, do you qualify and how do I know if I qualify? Well, these things are all based on guidelines and covered by various insurances. And it's pretty well accepted that anybody who is between the ages of 50 and 80 years old, who has smoked an average of a pack a day for 20 years, or quit in the last 15 years should the recommendation is for a lung cancer screen. Now, these things are changing. A few years ago, the guidelines did change. It used to be 55 years old, now it's 50. So we'll check back in 5 years and see what the guidelines are. But those are the guidelines as of right now. I will say with everything that we do, there's nuances. There's different guidelines that set an age cutoff. So there are some guidelines that suggest 77 or 78 or 80. So I always tell my patients that after the age of 75, we do have to check on a yearly basis as to whether they'll be covered based on the guidelines that their insurance covers. The screening process is generally through primary care physicians, or if you see an oncologist or a pulmonologist in clinic, they might recommend it as well. But it's a pretty simple thing to do. Like I said, it's a CAT scan that takes about 3 to 10 minutes and can just be ordered through any physician. So the purpose of screening in any cancer really is early detection. The difficulty with lung cancer is that lung cancer, when it's caught early, does not actually cause any symptoms, which is why we have to be very intentional about screening. There isn't a physical exam, there isn't a lab test. It really has to be a CAT scan. You could ask, well, why not doing a chest x-ray? Well, small nodules that may be suspicious wouldn't show up on a chest x-ray, so a CAT scan really is the best thing to do. We do see a lot of lung cancer diagnosed for different reasons, meaning somebody comes into the emergency room, gets a chest CT scan for a different reason, and we find a spot that happens to be that. But in that targeted audience that I talked about before in terms of the smoking patients, those are the people that we really need to be screening. So then you ask, why do we do it? Well, like I said, early lung cancers are very difficult to catch because they don't cause symptoms. So we have to be very intentional about looking for them. What you can see here is that on that blue graph is the number of cancer-related deaths by lung cancer. And what you can see compared to the next three, there are nearly as many lung cancer-related deaths as the other next three combined. And that's really why we need to focus on early detection of cancer. Early detection leads to overall improved survival. So this graph is a little bit difficult to look at, but what you're basically seeing is on the left side where it says localized, what that really means is an early stage. So about 27% of patients that we are diagnosing are at an early stage, and that's associated with a 64% 5-year survival. You'll see that as we move to the right where it says distant, those are patients who are diagnosed at a later stage, and that's nearly half the patients that we diagnose. You'll see that the 5-year survival plummets to around 9%. So the importance of these figures that I wanted to show you is really the importance of early detection, which is done through lung cancer screening. In terms of statistics related to lung cancer screening, it's really estimated that around 18% of those eligible have received screening. And various resources that we've looked at suggest that in the state of Iowa, we're roughly between 16 and 17%. So both in the state of Iowa and nationally, we need to be doing much better in terms of screening patients. We do know that various trials have shown a reduction of mortality in up to 20% of those who receive screening. Now, I will say with everything that we do in medicine, nothing is perfect. Just like every medicine has a side effect, these CAT scans can sometimes show spots that may not be a cancer. Particularly in the Midwest, and especially in the state of Iowa, we do see a lot of people with pulmonary nodules, and not 100% of them are cancer. In fact, a lot of the spots are not cancer. We see a lot of things like granulomas, which are related to old fungal infections and things like that. So it is possible that if you get a lung cancer screen and that there is a spot that's detected, that might be a false positive test, which might lead to more testing. But again, the importance of the screening for the patient population still stands. So let's talk about what happens next after you get your CT scan. And I just wanted to show some pictures about some CT scans and talk about the patient journey from start to finish. This is a picture. So these are two pictures of stage 1 lung cancer, and these are de-identified cases, but real cases that we have seen. So on the right is a CAT scan, and what you'll see in the red circle is a very small nodule. And what you'll say is, well, it looks like there's little spots everywhere. Well, we look at these CAT scans a lot, so we can tell that that thing is a nodule and those other things are blood vessels. And this was a patient who qualified for lung cancer screening, and that spot itself measures around 8 millimeters. With respect to size, that's actually pretty small. And there's a lot of different options with that. On the left side, you'll see what's called a PET-CT scan. It's a different type of picture done through radiology where they inject a tracer, which identifies different various levels of activity. The way we use PET scans isn't necessarily to diagnose cancers, but to increase or decrease our suspicions for cancers. But also, if somebody has a known cancer, it really helps us identify where that cancer may have spread to. So you'll see that color scale on the left with that 8 and the 0 and the bright yellow versus the dark. The brighter something is, the more activity it shows. It's a little bit hard to see, but that nodule does show some activity. But it should be said that that nodule is so small that sometimes nodules that small don't show activity. So this is what we would call a stage 1 lung cancer. And if we go to the next picture, what you'll see again on the right is a picture of a CAT scan, and that spot on the right is much easier to see. And I think it's easy to say that that's much larger. What you see on the PET scan there is that bright yellow color. And then you'll see a bright yellow color in the middle of the chest as well, and that's actually a lymph node. This is what we want to prevent. So what this means is that this patient was biopsied and was determined to have lung cancer, and the PET scan determined that the cancer has already spread into the lymph nodes of the body. And so that means that statistically their 5-year survival has gone down, and their treatment will change tremendously. And this is another picture. The picture on the right is a little bit harder to see, but this is a more advanced lung cancer. And so you can see where that red circle is where the cancer is. But then if we go to the PET-CT picture on the left, what you see is the bright yellow area in the center, which is the lymph node. But then you see at the bottom of the screen where the bone lights up yellow. So this would mean that the cancer itself has spread outside of the chest and outside of the lung. And this, unfortunately, is a patient who has stage 4 lung cancer. And if we think back to our statistics of their 5-year survival, all of this again points to say the importance of lung cancer screening. So if we think back to those pulmonary nodules that we were to see, we would ask ourselves, what would be the best way to biopsy these nodules? Because truly the only way to diagnose somebody with a is a biopsy of some sort. As I said, in the past 10 years or so, pulmonary diagnostics have really made tremendous advancements. Historically, these nodules would be very difficult to biopsy. And to be clear, they still are, but we've made a lot of advancements to make ourselves more precise and to really increase our yield for diagnoses in a fairly safe fashion. If you see the picture on the right, that's really a picture of what we call a trachea and bronchial tubes. In general, if we were to do a bronchoscopy, which means a scope going down through the airways, the bronchoscopy or the scope does not travel very far, roughly just to the first takeoff where that red ends. And so if we have a nodule at the very small spot of those airways, it becomes very difficult to biopsy those things. Well, with technology, we've developed what we call navigational bronchoscopy. And so what that means is that we use a computer system. We mark the spot on the computer through using a CAT scan. And then when we set up for the procedure, we actually have a machine that helps direct us where to go with the catheter. So we can actually stick catheters in much farther to reach places. And ideally, we can access really anywhere in the lung fairly safely. The procedure itself is minimally invasive. It is done under general anesthesia, but has been shown to have very short recovery time It's a same-day procedure with very few complications. This is a picture of navigational bronchoscopy, and we use different radiology techniques all at the same time. So what you see on the picture at the very top is what the computer is allowing us to see. So that green tube is our catheter, and it's pointed towards a blue dot, which is where we want to then stick our camera. Our camera is an ultrasound, and so if you look at the bottom left of the screen, you'll see an ultrasound with what looks to be a dark sun, is what I call it. Once we feel like our catheter is in the right spot, we will take a very small probe that has an ultrasound and we will stick that ultrasound out. How do we know where the ultrasound is going? Well, in the center of the picture there, you can see our catheter with what we call fluoroscopy, and we can see our ultrasound sticking out through the catheter. So we use fluoroscopy and ultrasound at the same time. And if we get that good dark sun picture, we know that we're in the right spot. From there, our catheter can just sit there, and we have different tools to try to take biopsies of it. We have an anesthesiologist in the room, which helps keep people sedated. And then we actually have a pathologist in the room too to make sure that we're getting the sample that we need. So let's go back to the start. So how do you get screened? Well, the first thing first is to talk to your primary care doctor to see if you do qualify. Really, the qualifications again are being between the ages of 50 and 80 years old, 20 pack year history of smoking. What that means to say is you smoked an average of 1 pack per day for 20 years. So half a pack per day for 40 years. And if you've quit in the last 15 years, you would still qualify for that. Things do change, and so it would be reasonable to check with your primary care provider on a yearly basis to see if you qualify. If you do get a lung cancer screen and it's normal, then you would qualify for another one in another year, as long as you still fit that criteria. If they do show a suspicious spot, what generally happens is a referral to our clinic. And so you'll meet either me or my partner, and we will talk you through different options. Like I said, not everything that we see is lung cancer. So we may say, well, based on the size and risk factors, we're just going to order another CAT scan in maybe 3 months or 6 months. We may talk to you about a PET scan, like we saw pictures of that before. Or we may say this is something that we should get a biopsy of. Let's assume that we're going to go ahead and get a biopsy. If we get a biopsy and we do establish a diagnosis of lung cancer, there's other tests that you're going to get, the PET scan like we talked about, and a breathing test, and likely an MRI of your head as well. From there, we'll be able to know what the diagnosis is, what the stage is, and what the treatment is. In general, the treatment for these types of things is surgery, chemotherapy, immunotherapy, or radiation therapy. And based on the type and extent of it, you might see all of those physicians to help determine the treatment plan. I think at this point, it would be a great idea to have Dr. Tofilon talk to us about advancements in lung cancer treatment.
Great. Thanks, Dr. Mahyni, for sharing your expertise. And of course, I just want to remind folks as we transition here to Dr. Tofilon that if you have questions, feel free to be typing those into the Q&A. I'm monitoring them. We're getting some in, and we'll share those with both physicians at the end of it. So Dr. Tofilon joins us as medical oncologist based in our Fort Dodge practice. Dr. Tofilon, you're going to share more about the diagnosis, from diagnosis to treatment options.
Thank you. And just want to thank everyone for attending today as well. We'll be happy to take questions at the end. So I just wanted to speak a little bit about some of the newer treatments that we have for lung cancer, particularly for advanced lung cancer. As Dr. Mahyni stated earlier, the survival rates for advanced lung cancer have been pretty poor in the past when we were treating patients just with chemotherapy alone. And so there's been a huge amount of advancements in treatment over the last 10 to 15 years with some of our newer treatments called immunotherapy and targeted therapy. And so I just wanted to start off with a slide here that just sort of speaks to the difference between chemotherapy and some of our newer treatments. So in the first part there, you can see that it's talking about chemotherapy. As most of us know, chemotherapy kills both good, healthy cells and sick cancer cells. You can see the yellow cancer cells over the chemotherapy column there. And then the pink cells are our healthy cells. So the chemotherapy goes in the system and it kills both healthy and sick cancer cells. And because of that, chemotherapy tends to have a lot of side effects, as most of us are aware. And it really doesn't work that well by itself for lung cancer. So targeted therapy is the second column there. And there are some lung cancer patients who have a specific target on their cancer cells that we have a drug that will actually go to that target and kill those cells. And so you can see the pink arrows there are the medication that is going to the target on the cancer cells. And because of that, those therapies tend to have a lot less side effects than chemotherapy does. So that's a little bit about targeted therapy. We'll talk more about that on the later slides. And then immunotherapy. So immunotherapy uses our own immune system to fight the cancer cells. And so again, you have your yellow cancer cell, but the blue cells around it are some of our immune system cells that then we are using to fight the cancer. So that does tend to have less side effects as well than chemotherapy. So let's talk a little bit about what immunotherapy is. So immunotherapy are medications generally given through the vein that harnesses the power of our own immune system to fight the cancer. I like to think of it as akin to what our immune system does with an infection. So when we are exposed to a viral infection, our immune system becomes more active. It recognizes the virus as a foreigner, something that shouldn't be there. And so our immune system gets revved up, all of its T cells and B cells start becoming active, and those cells go to the virus and kill them. They get rid of the foreigner. So the way immunotherapy works is it tells our own immune system to turn on, to become more active. And then the goal with that is that our immune system will recognize the cancer as foreign, just like it does with a viral infection. And then we will use our own immune system to help kill those cancer cells. I'm sure that many of you have seen the many commercials that are on TV for medications called Keytruda and Opdivo. Those are our most commonly used immunotherapy drugs. A lot of times I think things are over-advertised on TV, but these medications have truly been transformative in lung cancer. It is amazing the difference in the treatment of lung cancer, the treatments I give now versus what I was giving when we started, or when I started practicing, and the survival rates that we're seeing since we've started using these medications. So benefits of immunotherapy, probably the biggest one is that it is tolerated so much better than chemotherapy is. So as many of you probably know, chemotherapy tends to have a lot of side effects: nausea, hair loss, diarrhea. And there are some patients who I see either because they're in their 80s or 90s, or they're just sick either from their cancer or from their other chronic medical issues. There are some patients who just could not tolerate chemotherapy. But those patients are often good candidates for immunotherapy because the side effects tend to be so much less. They're not without side effects completely. We do tend to see a lot of fatigue, sometimes rashes, but in general, people do a lot better with immunotherapy than chemotherapy. Another benefit of chemotherapy, or excuse me, of immunotherapy, is that when these drugs work, they tend to work very well. Often with chemotherapy for lung cancer, we'll have a short period of time where the chemotherapy works, but then it stops working. And that will often happen just over a period of months. With immunotherapy, if we have a response, often patients' cancer will stay under control for years at a time, sometimes even after they've stopped the immunotherapy and are no longer having treatment. And that was things we just never saw with chemotherapy. And probably the most important is that, I'll have you go back, please, is the improved survival that we have seen since adding immunotherapy to our treatments. So as Dr. Mahyni said in his slide earlier today, before immunotherapy, the chance that a person with advanced lung cancer would be alive at 5 years after their diagnosis was about 10%, which is pretty paltry. Since immunotherapy has been added, now the survival rates are somewhere in the 20 to 25% at 5 years. So that's about a doubling of the survival. And so it's a vast improvement, but obviously we still have a ways to go with that. So next slide. So drawbacks. So yes, most people who get immunotherapy do very well with it, but there can be some rare, very serious side effects. If the immune system becomes too active, it can start attacking some of our normal healthy tissues. So we've seen things with diarrhea, with inflammation in the lungs, thyroid issues. So we have to monitor these patients very carefully with blood work, with talking to them about their symptoms. And so again, while most people do well, we do have to watch out for those more serious side effects. And then some patients are just not candidates for immunotherapy. The most common reason for that is if patients have serious autoimmune diseases, things like lupus, sometimes rheumatoid arthritis, or if they have had an organ transplant, they may not be a candidate for these drugs because we don't want to be altering their immune system even more. So uses of immunotherapy in lung cancer. Pretty much almost every patient who has stage 4 or metastatic lung cancer will have immunotherapy as part of their treatment, either alone or combined with chemotherapy. The first studies with immunotherapy in lung cancer were done with these patients with stage 4. But now we're starting to find the immunotherapy works in earlier stages as well. And so we're starting to use them for patients sometimes prior to surgery to try to shrink the cancers. Sometimes we're using them after surgery or even after chemo and radiation as more of a maintenance type of treatment. And I suspect as more studies continue, we are just going to find more and more situations in lung cancer that we're using these drugs because they've been extremely effective. So that's immunotherapy in a nutshell. And then we'll talk a little bit about what targeted therapy is. So targeted therapy is very different from either immunotherapy or chemotherapy. So immunotherapy and chemotherapy are not specific at all. And what I mean by that is they go in the system, they look for cells to kill, and they kill the cells. There's no specific target that they're looking for. So with targeted therapy, these are medications that are looking for a specific abnormality on the cancer cell. So everyone's cancer cells have different abnormalities. And we have, for certain abnormalities, we have drugs that actually target them. And so whenever a patient is diagnosed with advanced lung cancer, we do something as part of their workup with the PET scan and the biopsy and all of those things. We also do something called molecular profiling. So what that means is we take the cancer cells, we look at their DNA, and we try to find out what abnormalities they have, what mutations they have in their particular cancer cells. So it's kind of a fingerprint or a profile of what each individual patient's cancer cells look like. So 30 to 40% of those patients will have a target that we have a drug to treat that with. And this is probably the biggest benefit of these targeted therapies is it really allows us to practice more individualized medicine. And what I mean by that is 15 years ago when I started practicing, every patient with advanced lung cancer got the exact same treatment. They got chemotherapy and you hoped that it would have some positive effects. Now, when a patient comes in to see me, I look at their molecular profiling, see what abnormalities they have in their cancer cells, and I may see one patient in the morning who has abnormality A and gets treated with drug A, and I may see a patient later in the day who has the same type of cancer, the same areas of cancer in their body, but they may have abnormality B, and so they may get a completely different drug. And so, like I said, it's allowed us to practice more of that individual medicine, really more targeting our therapies to each individual patient instead of just giving them more generic drugs for lung cancer that we hope will be effective. So just to give you an example of one of the types of abnormalities that we're looking for. So there's something called the EGFR mutation, and you don't need to remember the name of that. That is the most common mutation or abnormality that we see in advanced lung cancer. About 10 to 15% of patients with stage 4 lung cancer will have this abnormality. Thankfully, researchers have developed medications that target that abnormality, and I've listed some of them below. There were drugs that were developed a few years ago, and now we have newer ones that have been developed that are more effective for this type of mutation. And if you go and look in the literature, there are multiple abnormalities or mutations that we do have drugs to target. And again, this field is just exploding. It is honestly difficult to keep up at times with all the new targeted therapies because of all the research that is ongoing. Just to talk about how this is improving survival rates as well. So again, prior to these new treatments, about 10% of patients with lung cancer lived for 5 years. And these patients with EGFR mutations, the survival rates with these targeted therapies have improved to about 30 to 35%. So that's about tripled the survival, which is a huge improvement compared with previously. So the benefits of targeted therapy, in general, they also have fewer side effects than chemotherapy. Most of the time, these medications are pills. We do have some that are given through the vein, but a lot of them are in pill form, which is more convenient for patients. They do have fewer side effects, but they're not without side effects either. They tend to have some different side effects than chemotherapy. So we've seen high blood pressure, rashes, diarrhea. So again, just like with the immunotherapy, people do well, but we've got to keep a close eye and monitor them. Another benefit, like I said earlier, is just that specificity to each individual patient's tumor. And as I showed on the last slide, it's these drugs are definitely making an impact on patients' survival. The drawbacks with them, so not all patients are candidates. Like I said earlier, about 30 to 40% of patients right now have a target that we have a drug to treat that with. Again, I think that number will be going up substantially over the next few years. But because of that right now, not every patient is a candidate for the targeted therapy. There are some very rare and serious side effects that we have to monitor for. And the other issue with these medicines is that the cancer sometimes can become resistant to these drugs. So just like HIV, the virus, we had a hard time treating for a long time because every time we tried a new medication, the virus would find a way to grow and become resistant. And so we're seeing that with some of these targeted therapies. Right now, we're often having to change between different medications because of this. And sometimes we get to a point where we have exhausted all the targeted therapies and we end up having to treat these patients with chemotherapy anyway. So the resistance is a problem. Hopefully something that will be worked out as time goes forward. So that's just a little bit about some of the newer treatments. I did want to echo a couple of things that Dr. Mahyni said. I agree with him saying over the last decade, we have come miles and miles forward with treatments for lung cancer, but we obviously have still a ways to go. But screening is really such an important tool so that we can be treating these things early, not having to give all of these treatments like immunotherapy or targeted therapy, and get patients cured and back on their way to life. So thank you very much.
Thank you, Dr. Tofilon, for joining us as well and sharing your expertise. I'll have Dr. Mahyni go ahead and turn his camera and audio on because this is a time we'll move into question and answer. And we have been receiving quite a few comments and questions in, so I'll share those. As people are still typing here, I did want to ask the two of you, as you had statistics about the percentage of people who are getting screened that are eligible as being lower in the United States and specifically in Iowa. What barriers do you think exist for people getting this necessary low dose screening and determining if they have lung cancer cancer?
Uh, I'm not certain. I think the biggest thing is awareness. I can't say off the top of my head how long lung cancer screening has been a recommendation, but it's at least the better part of a decade, if not longer. Doesn't doesn't get a lot of publicity. There's not a lot of talk about it, and there's just not a lot of awareness about it.
I think part of it too, sometimes there still is some stigma with lung cancer and smoking being a cause. I think that might weigh into it a little bit. The other thing I think personally is the criteria are not 100% clear, especially when it comes to former smokers. You have to have quit within a certain time frame. And I think, with mammograms, it's generally once you're this age, although that's controversial too. Once you're this age, you do a mammogram once a year. With the lung cancer screening CTs, the criteria are just kind of messy, I think. And it doesn't make it super easy for a primary care physician to necessarily know if their patient falls in those criteria. So hopefully those with time may be cleaned up a little bit and maybe made a little bit more straightforward to make it easier to pick up patients.
Okay. One of our first questions was, can non-smokers be screened if two siblings had lung cancer, one a smoker and one a non-smoker?
Yeah, this is the unsatisfying part of lung cancer screening. I get a lot of questions about, as Dr. Tofilon was saying, the inconsistencies with lung cancer screening. It's pretty consistent in that in, 50 to 75-year-olds who have smoked a pack a day for 20 years qualify. Those who quit within 15 years qualify. But yeah, it's what if you quit 16 years ago, or what if you have a sibling who was diagnosed? So there are a lot of other indications where we would want to pursue screening. As of right now, there are no guidelines to pursue screening like that, even if it were to make sense. The issue then becomes, at the end of the day, would insurance cover that screen or not? And I think those are things to talk to your primary care provider about. But as of right now, unfortunately, the guidelines in that setting would not allow it. It's really for people who have smoked.
Okay. Next question is similar vein here. How about screening for exposure to radon? What percentage of lung cancers do you think are due to radon exposure?
I'll tackle this one too. I think this is one of the bigger issues, particularly in the state of Iowa, where we have a lot of radon. And the answer is also unsatisfying in that there is really no way to screen for that right now. I do recommend radon testing in people's homes and radon mitigation, but I also have to be clear with people as to say, well, if you have this exposure, there's really no definitive how much exposure, and then what can we do about screening. So as of now, there really is no radon screening guidelines to that we could recommend. But in terms of answering the question, it's estimated, it's hard to answer how much we think radon is contributing, but it's estimated that in non-smokers, it's likely the cause in about 10 to 15% of lung cancer in non-smokers. We also know that people who smoke who have exposure to radon, there is a synergistic effect of about a 20% increase in chance of lung cancer. But again, the question of screening for non-smokers, things may change, they always do. And I hope that does open up in the future. But that's unsatisfying in that realm.
Are certain patient groups more likely to have certain mutations? For example, a former smoker more likely to have the EGFR mutation. You were referencing that sort of mutation, Dr. Tofilon.
Yeah, so with the EGFR mutation, we know that the rates of that in Southeast Asia actually is very, very high. Something I think it's like 40 to 45%. And actually, those drugs were first developed and used in that area. So, yes, there is difference between cultural differences. We also know that some types of non-small cell lung cancer, there's a few different types. Some are more likely to have some of these abnormalities than others. And it seems like there is some association with non-smokers tending to have more of these abnormalities, more of the targeted therapy type of patients than smokers.
Okay. Another question that came in, the rates of new lung cancer diagnosis among Black population in Iowa is significantly higher than state and national averages. Black populations are also getting screened at lower rates because of several factors such as eligibility gaps, lack of awareness, financial and transportation barriers, etc. So the question is, how is McFarland addressing inequities in early detection and access to screenings?
That's a great question. I think, as the question alludes, there's multiple factors in terms of screening, and I think the biggest thing would be access to care. Well, access to care is a big umbrella term, which implies, transportation and access to physicians as well. I think things like this are important. I think our the most important thing that we can do in this setting is is trying to raise awareness. I think lack of awareness is the biggest thing. Like I said, if we can get patients to their primary care providers, there is a big push for lung cancer screening, not just with McFarland Clinic. McFarland Clinic is doing it, but a lot of other people are doing it. We have alerts on patients' charts if they do qualify so that a primary care provider can see that alert. Reminders go out through radiology departments to remind patients to get their screening. And so there's a big push on multiple levels. The biggest thing is trying to raise awareness, and hopefully that we can bridge that gap.
Okay. Dr. Tofilon, anything you wanted to add to that, or I didn't?
No, I think the awareness, also, October is Breast Cancer Month, and we see that all over the NFL and TV and everything. And it would be nice if we had that awareness for other cancers too, such as lung cancer. I think that would help.
And I'll tell a story to piggyback on that. I have attended a lecture on lung cancer screening back in fellowship, and the person who was presenting actually ended up getting into trouble because of a tangential talk on the awareness related to breast cancer versus lung cancer. And the point was valid. The delivery could be fixed, but the point was breast cancer does a great job in terms of awareness, and we do see runs and NFL and pink and lung cancer awareness programs need to rise up and get to that level for the statistics that we've shown.
Agreed.
Another question, can you talk about who's generally recommended for chemotherapy and what that looks like if it's used alongside targeted therapy and immunotherapy? And Dr. Tofilon, as you were speaking, I was thinking about, so the immunotherapy, is that a pill form? Is that an injection? I know you're talking about monitoring. I think sometimes we think about chemotherapy, I'm going somewhere and I'm going to be there for a while to receive this treatment. But yeah, the question, who is generally recommended for chemotherapy and how does that work alongside these other advances?
Yeah. So I'll start off with it's complicated, but I'll try to give an overview. So for just speaking about advanced lung cancer, so for stage 4, kind of the first thing we do is that molecular profiling to see if they are a candidate for the targeted therapies. So that's kind of the first juncture we get through. If they do not have any targeted therapies that they are a candidate for, then there are 2 options. One is immunotherapy by itself, and there are certain characteristics that the tumor has to have for patients to be a candidate for that. And then that's a small number. The vast majority of those patients will get a combination of chemotherapy and immunotherapy together. The immunotherapy is generally given through the vein, like chemotherapy is. And so the monitoring is pretty similar to when patients come in to get chemotherapy. They get their blood work drawn, we make sure all their levels look okay. They're seen by a physician or advanced practice provider, and then they go to the treatment room where they have their treatments. So that looks very similar with chemotherapy and immunotherapy.
Okay. So there were a number of individuals that were sending in similar questions about, I'm a non-smoker, or I've been around smokers, or somebody that has maybe mild controlled asthma, and wanting to know if they would be eligible for the screening, which you have addressed, and certainly they should be a conversation with their PCP. But this question is, what is the approximate cost of the CT scan for lung cancer, assuming insurance will not cover it? Do we know that?
I
I
don't know that.
that would be
Okay.
a question to reach out to, the radiology group and the business office of that group to see.
Okay. Okay. Um, a person is a breast cancer patient under the age of 50, would they be a candidate for a lung cancer screening?
Simply having breast cancer wouldn't qualify you for lung cancer screening unless you fit the aforementioned criteria. Um, I guess I would ask Dr. Tofilon, in my realm, when a patient has breast cancer and they're getting a CT scan, and correct me if I'm wrong, in general, if they have breast cancer, they are getting advanced imaging otherwise, which would include the lung to look to see if there's spots in the lung or elsewhere. And so not necessarily getting lung cancer screening, but screening for other things, which would then include the lungs. I don't know if that answers that question.
Okay. Uh, Vaping has grown. Is it as much of a concern if one was a former smoker like 20, 30 years ago, but vapes? So what's your thoughts on vaping?
Yeah, it's again not the vaping is new enough that that's not specifically mentioned in the criteria, but I if I have a patient who vapes, there's no way to quantify vaping versus pack years, and so I basically just try to equate it to smoking the best that I can and get them screened because I do think, well, the data is out on vaping. I think it's going to be clear that vaping is going to be as bad as cigarette smoking, if not worse, because of the things that come with the vape device.
Just working through the questions here. Besides radon, what else causes lung cancer in non-smokers?
A lot of environmental factors that are hard to put your finger on. We can't label one thing per se, but in general, environmental factors and genetic factors such as mutations, which is why I think, as Dr. Tofflin was, the targeted therapies. And so and Dr. Tofflin, correct me if I'm wrong, a lot of the times when we do make a diagnosis of lung cancer, that testing is then the specimen itself is actually tested for different types of mutations to look for. The way that information is used is for physicians like Dr. Tofilon to advise on specific targeted therapies like she talked about. Now, does that mean that your sibling also has to be tested for these mutations? In general, no. Is that something for the future? Probably as these things do advance. But as of now, no.
Dr. Top, this may be a question, well, maybe for both of you. NS cells versus small cell CA. You probably know what that technically, the question is the types of lung CA pathologies matter. Does
Yeah.
that question make
Yeah,
sense?
I can
Okay.
take that one. Yep, so there are two main types of lung cancer. There's non-small cell and small cell, and essentially it is what the cells look like under the microscope. Why they don't call it large cell anymore, I don't know, but it's non-small cell and small cell. Non-small cell makes up about 90% of all lung cancers, small cell about 10%. They are treated somewhat differently, so it does matter. Small cell tends to be more aggressive. We very rarely use surgery for small cell. Chemotherapy, radiation, and immunotherapy are typically the treatments for that. But again, it tends to be a more faster growing, more aggressive, more likely to spread type of lung cancer. And the vast majority of cases of small cell are smoking related, more so than with non-small cell.
Um, One of our directors with our radiology department has weighed in here on the question about insurance and cost for CT lung screening exam is roughly $650. That is charged to insurance here at McFarland. So again, it probably would be good to have a conversation with your primary care and also understanding too what your insurance covers with that. Just looking back through one other question here, I think we haven't touched on. maybe
will say,
have a bit, but this has to do with someone, if someone is, they're a spouse of a smoker, maybe someone who does qualify for the screening. But this individual has been in this household, and I guess we're getting back to secondhand smoke here. Is that something that they could possibly be eligible for? They've lived in the same household with the individual.
yeah, unfortunately, secondhand smoke isn't part of the criteria. I agree it should be, just like I think radon exposure, if we could quantify it, would be. But as of right now, it isn't. I will say, in terms of there are different ways to get pictures of the lung. So when we talk about lung cancer screening, we're talking about specifically a CAT scan for the purposes of lung cancer screening. There are a number of patients who end up in my clinic because they get a picture of something else that happens to include the lung. And so it's a very indirect way and it's not intentional screening, but it's possible that if you've had a CAT scan of your abdomen, that generally shows the bottoms of your lungs. And if you've had a CAT scan of your neck, that tends to show the tops of your lungs. And so while people may not qualify for lung cancer screening, they may have had pictures of their lungs taken through various CAT scans and not aware that the lungs show up on it. Calcium scoring CT scans, for instance, is commonly done in the cardiac world through primary care. The intention is to focus on the coronaries, but the lungs are just next to that. And so it shows about 80% of the lungs. So there, while it's not a screening test per se, there are backwards ways of getting pictures of the lungs taken for other things.
Okay. Another great question. I know we're going to wrap up here in a minute. I think this is an excellent one as well. There's been some great questions and dialogue. How can different stakeholder groups, patients, caretakers, clinicians, advocate to change the screening criteria? What is required to change screening criteria?
Guess I don't know what would be required to change criteria other than more public awareness and dissatisfaction with the current criteria and making the guidelines change. And I think the guidelines are really directed by various groups done through statistical analysis and data analysis and then ultimately up to the providers to enact the guidelines, but then insurance to assist patients with the cost of going through that. And so I think the first step, like we've talked about, is just raising the awareness for these things.
Okay, very good. Just have a minute or so. Any other comments? You want either one of you want to share last thoughts or takeaways in regards to any of the information you've covered or anything else you want to mention?
I would just advocate patients talking with their primary care providers about what screenings, not just lung cancer, but all screening tests for cancer that they might be a candidate for. I've really seen over my career the difference that these screenings make in terms of survival and also just morbidity of having to go through treatments and the difference between a cancer that's been picked up with screening and one that's been picked up much later. So I would say screenings all day long. And just be aware of your body. Be aware of any symptoms that you're having, and if they're unusual for you, get them checked out. That would be the other thing I would add as an oncologist. So,
Okay. Dr. Mahyni, anything?
No, the awareness, and screening. That should be
yeah.
doing. After that, we take it from there.
Well, thank you both for taking time to be able to share this information, share your expertise. We greatly appreciate it. And again, for anyone who's registered for this webinar, a link will be emailed out to the recording. And as we've heard from our physicians here, awareness and sharing and advocating, share this recording with your family and friends. to make them aware and that opportunity for them, if they qualify for the criteria, to be able to get the lung cancer screening. So again, we'll offer a survey here at the conclusion, and we appreciate you being with us today. Thank you.
Thank you.
Thank you.